Neurology quiz number 72. Describe clinical features, pathogenesis, and treatment of restless leg syndrome or RLS. RLS is a chronic neurological disorder that interferes with rest and sleep. The key clinical feature of RLS is the irresistible urge to move the legs, either by itself or in response to uncomfortable paresthesias of the legs. Moving the legs or walking improves the urge. Many terms are used by the patients to describe their paresthesias, and these are mentioned. Symptoms occur after a period of relative inactivity and typically develop in the evening or at night, often appearing 15 to 30 minutes after reclining in bed. They may worsen as the night progresses but resolve by the earlier hours of the morning. In milder cases, patients fidget, move in bed, and massage their legs for relief. With severe symptoms, patients feel forced to get out of bed and pace the floor for relief. In severe cases, symptoms can occur earlier in the day while the patient is seated and interfere with activities such as attending meetings, sitting in a movie theater, etc. This is a graphic which shows the different kinds of sensations experienced by the patient. Location: the leg paresthesias most commonly occur distal to the knee and the back of the leg in the calf region, but can occur in other areas such as the thigh or even the arms. Symptoms are typically bilateral. Physical examination is usually normal but may identify findings related to secondary causes. Prevalence of RLS is 1.5 to 2.5% in the United States, and it is twice as high in women as compared to men. About 60% of the people with RLS have a family history of the condition. The genetic component of RLS is consistent with an autosomal dominant pattern. Some of the genes associated with RLS are mentioned. RLS is divided into early onset less than 45 years and late onset more than 45 years. Early onset has a peak incidence at 20 to 40 years, is often familial, and has a slow evolution. Late onset is less likely to be familial, but associated comorbidities are more common, especially iron deficiency, and it can progress rapidly. This is a body diagram showing the sites of paresthesias in restless leg syndrome. Conditions associated with RLS: iron deficiency, pregnancy. Prevalence in pregnancy is 2 to 3 times that of the general population and most often occurs during the third trimester and resolves in the first month after delivery. Such patients have increased risk of RLS in subsequent pregnancies and of developing chronic RLS. Chronic renal failure. RLS has been observed in 25 to 50% of patients with ESRD, and symptoms are typically worse during hemodialysis. Medications associated with RLS include antihistamines, neuroleptics, tricyclic antidepressants, SSRIs and SNRIs, lithium and beta blockers. Other conditions associated with RLS are peripheral neuropathy, folate and magnesium deficiency, and Parkinson's disease. These are the International Classification of Sleep Disorders diagnostic criteria for RLS. Pathophysiology: iron and dopamine systems may be involved in the pathogenesis. Iron: although serum iron is often normal, patients with RLS have a low iron state in the brain as demonstrated on imaging, CSF studies, and pathology. Areas most affected include the substantia nigra, putamen, and caudate nucleus, endothelial cells of the blood-brain barrier, which normally serve as an iron reservoir for the brain, may lack sufficient iron reserves to meet physiological demands in patients with RLS. Dopamine: though response to dopaminergic agents suggests dopaminergic deficiency, physiological studies indicate a hyperdopaminergic state with dopamine receptor downregulation. There is a circadian rhythm of dopamine activity with hyperfunction in the morning and hypofunction in the evening and at night time. The dopamine receptor downregulation and low dopamine activity at night create a state of relative dopamine deficiency and RLS symptoms. Dopaminergic medications in the evening correct this relative decrease. However, this exacerbates the situation in the long run with further downregulation of dopamine receptors, and this may explain the basis for augmentation. Treatment: A. Iron replacement therapy. Iron supplementation should be prescribed with serum ferritin level less than 75 nanograms per ml or transferrin saturation less than 20% or both. Ferrous sulfate 325 mg BID is most commonly used. If the oral form is not tolerated or effective, IV iron can be considered. Serum ferritin and transferrin levels should be reassessed 12 weeks post-treatment. Optimizing the iron status can relieve RLS symptoms without further intervention, but response can take several weeks. B. Dopaminergic medications. FDA-approved dopaminergic medications for RLS include ropinirole, pramipexole, and rotigotine patch. These drugs are effective in the short term, but augmentation is a risk with long-term use. Typically, augmentation presents as an earlier time of RLS symptom onset, increasing severity of symptoms, spread to the arms, and shorter treatment effect window. Increase in the dose of the medication can lead to further augmentation, and therefore it is recommended to use lower doses of these agents. Carbidopa-levodopa carries a high risk of augmentation, and therefore dopamine agonists are generally preferred. Rotigotine, because of its longer duration of action, may carry a lower risk of augmentation. These are the dopaminergic agents used for treatment of RLS. Important points to note are the timing of the medication and the fact that doses used are much lower than in Parkinson's disease. C. Calcium channel alpha-2 delta ligands. Gabapentin and acarbal, a long-acting form of gabapentin, is FDA approved for treatment of RLS. However, it is expensive and insurance coverage is variable. Evidence also supports the use of gabapentin, and pregabalin is as effective as pramipexole with less risk of augmentation. Guidelines for RLS treatment published in 2016 encourage the use of alpha-2 delta ligands as first-line treatment over a dopamine agonist because of the risk of augmentation with the latter. This is the dosing of the alpha-2 delta ligands that are used in RLS. Again, it is important to note the timing of the medication. D. Other medications. Opioids can be used for severe RLS. They are typically used when other medications fail. Medications used are codeine, oxycodone, methadone, and tramadol. Long-acting agents may be more beneficial. Benzodiazepines like clonazepam are sometimes given, but strong evidence for their use is lacking. For all drugs, timing is important, and any agent used must have onset of action when the patient's symptoms start. RLS that begins early in the day may require multiple small doses. This shows the dosing for the opioid agents used in RLS management. E. Non-pharmacological interventions. These include reducing intake of caffeine and alcohol. Massage, stretching, and walking may be beneficial. Pneumatic compression devices provide a form of counter-stimulation to the legs and have been shown to provide benefit. Periodic leg movements of sleep, PLMS. These are highly stereotyped leg movements that occur during sleep. There is extension of the big toe and partial flexion of the ankle, knee, and sometimes the hip. Occasionally, arms are affected. It is reported in 90% of RLS patients, but is also reported in sleep apnea, REM sleep behavior disorder, and narcolepsy. Polysomnography can quantify severity of PLMS. PLMS can be associated with increase in heart rate and blood pressure and possibly increases the risk of developing cardiovascular disease. In patients with RLS, the PLMS responds to the medications used for treating RLS.